Hello, listeners. I'm your moderator, Alex Spiess, Division Chief of the Department of Plastic Surgery at the University of Pittsburgh Medical Center and Hand and Peripheral Nerve Section Editor for ASPS EdNet. On today's episode of ASPS EdNet Hot Seat, we will engage in a roundtable discussion entitled Replantation in the 21st Century. We're lucky to be joined by three distinguished guests who will provide their insight into this topic, which has seen significant evolution from the days of the first successful digital replant in 1965 by Komatsu and Tamai. Drs. Paige, Suhail, Mithani, and Bauback Safa will be talking to us about their experience with replantation in a major academic center, how their indications for replantation have evolved, thoughts on regionalization of care, and strategies for training the next generation of replantation specialists in an age of contracting medical resources and concern for physician well-being. At this point, I'd like to have each of our panelists introduce themselves. Paige, why don't you start us off?
Hi, my name is Paige Fox. I'm at Stanford University, where I'm an associate professor of plastic surgery and part of the hand section there, along with 9 other colleagues who split our replant call.
Hi, I'm Suhail Mithani. I am at Duke, an associate professor and vice chief of the Division of Plastic Surgery, and I work in a mixed combined hand division that's shared between orthopedics and plastic surgery, along with 7 other hand surgeons.
Hello, I'm Bauback Safa with the Bunkie Clinic. I am one of 6 surgeons here at the Bunkie Clinic. We're all hand and microsurgeons, and most of our practice is dedicated to the upper extremity, specifically trauma of the upper extremity.
Okay, excellent. Well, thank you once again for joining us today on the podcast. With those formalities out of the way, why don't we get on with the podcast? Bauback, I'd like to start off by getting your thoughts on how your approach towards specific aspects of digital replantation have changed over the course of your career. For instance, your thoughts on replantation of digits in Zone 2, single digit amputations in Zone 2.
Thanks, Alex. So I would say that in general, compared to when I was a resident, for example, or even when I was a fellow, I think we've become somewhat more aggressive in salvaging parts, even single-digit Zone 2 injuries. I think if the patient desires a replant and the patient is reasonable and the replantation is technically feasible and there's kind of a reasonable expectation for functional gain, I think we're certainly willing to give it a shot. We actually published our series of index finger Zone 1 and Zone 2 replants. This is, I think, in late 2000s, maybe 2009 or so. And what we actually showed was that even the Zone 2 results from a total active motion standpoint after tenolysis procedures were done, so once the patient was completely finished, were no worse than the classic Strickland flexor tendon Zone 2 repair total active motion. And so we were showing fairly good results, especially if you're willing to go back and do these revisionary operations. So in general, we tend to be a little more aggressive now than we were, let's say, 20 years ago or so. And I think some of that is borne out by data, but also a lot of it is really kind of patient desires. And we tend to be fairly aggressive if the patient really wants it up and wants it done, and they demonstrate understanding of what it takes to make the functional outcome better, including hand therapy and revisionary operations down the line. We're certainly willing to try it.
How about your thoughts on Zone 1 injuries?
Yeah, I think Zone 1 injuries, the function can be excellent, actually. And so we do really like doing Zone 1 injuries, even fingertips, even to my Zone 1, so very distal Zone 1 injuries. I think once you're distal to the FTS insertion, you can get very good results. And I think not only that does it aesthetically look really nice, but I think even functionally, the function can be quite good. Now, we happen to be in an area where cold intolerance may not be as big of an issue as other parts of the world. So I think that is one consideration potentially. But overall, our functional results in Zone 1 are actually quite good. So we tend to be fairly aggressive with doing those.
Paige, same questions. Your thoughts and how they've evolved on replantation of single digits in Zone 2.
Yeah, thanks. I think that I mimic Bauback in some ways. I definitely am having an honest conversation with the patients on that night for as much as almost always at night, for as much as they can be involved about what it really takes to get to a functional digit, and having them drive that conversation and drive that decision-making process if I really think that they understand. Because as Bauback mentioned, it's not just putting the finger on that makes it functional, but it's really the steps, the tenolysis, the hand therapy, and those kind of things that really make the great results. Just put the finger back on is not enough. That will just give them a stiff digit. So I find that I have a mix of patients, some patients that say, yes, no matter what, put it back on, please. But I have a subset of patients that say, absolutely not. Like, I cannot spend 6 months on the tip of my index finger. I have to go back to work. And so I try to really be honest about that conversation. And I would say that plenty of patients say to me, no, I'm not doing this. And I appreciate that realistic view of how long it takes and the number of surgeries it takes for the tip of the index finger in some cases. If that's a thumb, it's totally a different question.
Do you think that your opinion has changed or your attitude or approach has changed from early on in practice to now with respect to single digits in zone 2?
I think I have the ability to be more honest with the patients. Not only have I seen my own replants, but I've seen other people's replants come back. And a lot of people have a stiff, painful digit. And so I can tell them these are the things it takes to get to a mobile painless digit, and this is how long it takes to get there. So I think with experience, I'm able to be more honest, not just what I've read in manuscripts. And I think that's where my experience has changed. But I definitely also know that you can take that stiff, painful digit and make it a fairly painless digit with great motion. And so I'm willing to go down that treatment with someone if that's what they want.
And how about zone 1 injuries?
I don't see too many zone 1 injuries, to be honest. I'm not sure if they're just not making them to my doorstep, because the majority of ours, and I think it's the same for Bauback too, the majority of ours don't walk in the emergency department door. They get transferred into us. And so I don't get too many calls for zone 1s. So I don't know if those gets scanned out before me, but certainly if someone with a zone 1 came, you can get a really nice results past the FDS insertion. So I would go for it if that's what they want.
And Suhail, I'm going to ask you the same 2 questions. Your thoughts and your evolution of care since you began practice and today with respect to treatment of zone 2 amputations of a single digit.
I think that the one place that I'm probably less aggressive than I used to be is in the periarticular injuries around the proximal interphalangeal joint. And I had a tendency before to be more willing to shorten into a fusion or accept an imperfect joint. And I found that I struggled to overcome that despite how much therapy or revision surgery that I could do. And so that's where I kind of counsel patients on the night of injury a little bit more in that regard. Certainly, I think that Bauback's data from the Bunke Clinic is really true. If you and the patient are willing to put forth the effort, you can get an outstanding result with a single digit zone 2 type of injury. And I think that everybody deserves a chance. I think many times on the night of injury, it's really hard for patients to have a true conversation with kind of equipoise with you in that regard. So my tendency is to be more towards trying to do the replant as opposed to talking the patients out of it. But I do have that pause in the periarticular injuries. I will say that my zone 1 replants have been the most grateful and happy patients that I've taken care of. It's an easier rehab distal to the FDS insertion, and they're very grateful. And I think that some of the functional issues are less problematic. Even periarticular around the DIP joint, ending up with the DIP fusion is not a significant functional loss for many folks. And so I think that they're happy to have their fingers.
You bring up a great point about the periarticular injury. Does your attitude towards periarticular injury change as you go from the index finger to the small finger? In other words, are you more aggressive about the index finger, less aggressive about ring and small?
Yeah, I think that's fair. I think having a stiff small finger is a real hindrance to people. I can't say that like in real time, I tend to be able to experience that kind of subtlety. I think I will counsel around the PIP types of injuries, but I'm not sure that I can convey in a reasonable way to a patient that suffered this kind of trauma what the distinction is between those. So I tend to not get into it. I mean, I have had that conversation downstream with folks, and I've had more than a couple of folks that even after a successful replantation, they subsequently underwent a revision amputation. And I think those patients are grateful for the opportunity and relieved to be done with the process as well.
Paige, how about you? Do you feel obligated to counsel a patient if, for instance, they're interested in a replantation through the PIP joint of the ring finger, for instance, versus the index finger? Is there a set discussion that you have with them with respect to their expectations for the overall outcome, if successful?
Yeah, I think the index finger is so easy to pass point and use any other digit that the index finger, sometimes if it's even the slightest bit stiff, the patient isn't using it well. Even if you've had a great replant and you've got a fairly mobile digit, they're still not incorporating it in their everyday life unless they're making that as a conscious decision. So I do talk to them, especially as Suhail pointed out, if this is through the PIP joint and I know that PIP needs to be fused, it's never going to move, it wasn't a sharp laceration, then on the index finger, I'm probably thinking about that differently than I'm thinking about it on the small finger. Interestingly, patients, not being hand surgeons, don't realize what their small finger contributes to their power grip. So they think, oh, it's my small finger, that doesn't matter, save my index finger. So as a hand surgeon, you can help educate them on that difference and where the importance comes in the ring and small finger.
Bauback, do you take pause if you are approached with a amputation through the PIP joint of somebody, with an amputation of the small finger through the PIP joint where you are going to be required to fuse that PIP joint? Do you take pause in recommending replantation in that scenario?
Yeah, I think as has been already discussed, more so for the small finger and the ring finger than for the index. Index and middle usually are more pinching fingers, and ring and small are usually more gripping fingers. And you don't really get much of a quadrigid type effect by having a stiff PIP joint of the index finger. So in my experience with a proper fusion angle of the PIP, the patient can still use that to pinch objects. However, if you have a really bad PIP joint of the small finger, that's a big deal. And so from a functional standpoint, I think the PIP joint is pretty much trashed on the small finger. It's probably not worth putting that back on. Having said that, that completely changes in multiple digits, obviously. So this is strictly a single digit discussion. If you have multiple digits all through the PIP, you're going to put those back on. But if it's just a single digit, I think the more ulnar I go, the more pause I have if it's a single digit.
Staying with you, Bauback, what are your post-operative anticoagulation protocols, if you have any at all?
Yeah, so interesting enough, we used to be big dextran users many years ago. We haven't really used it in about maybe 7 or 8 years now. Our post-op protocol basically is a baby aspirin for about a month. And for injuries that are either very distal, like a distal fingertip where the vessels are really, really small, really severe crush avulsion injuries requiring vein grafts, we will do low-dose heparin. Usually that's about 500 units an hour for an adult. If it's a really large adult, maybe a little bit more, 750, but definitely subtherapeutic. We tend not to kind of heparinize between PTT of 60 to 90, for example, for our replants as much. If we're doing basically a artery-only protocol where we're bleeding the patient, we titrate the heparin to visible oozing of the blood from the fingertip. So that's kind of when we titrate the heparin. And we don't necessarily shoot for a therapeutic level, we just shoot for something that gives us kind of a slow ooze of the blood. But if it's basically a straightforward replant where we did do a vein, we either do aspirin alone or at the very most we'll add some low-dose heparin to it. We actually have a paper that I co-wrote with Kyle Eberlin on the use of leaching in distal digital replants, but part of that also deals with our anticoagulation protocol, and that came out in, I think, JHS fairly recently.
If you've started somebody on heparin, what is the time frame with which you are utilizing that heparin? How many days do you have that patient on heparin?
Yeah, so it's a tough call. A lot of it really depends on what the part looks like and how severe the injury was, but it's usually about 5 to 7 days. If it's a fingertip artery only protocol, what we typically do is we kind of titrate the heparin down, maybe cut it in half on day 5, 6, 7, whatever we decide, and then we kind of look at it and see how it looks. And if it looks like it's decent, it's not getting congested, then we just turn the heparin off the morning of discharge, maybe 4 or 5 a.m. and see how it's doing the next few hours. There's no exact protocol per se, but usually between days 5 to 7.
Paige, how about you?
I think a lot of the same things. I don't use anticoagulation with heparin or dextran regularly. I go with aspirin for everyone who can tolerate it, that doesn't have a contraindication to aspirin, and then only use heparin if there's been some problem intraoperatively, if we had a clotting or we had to use a vein graft or some issue that made the replant less straightforward, then again, a low dose heparin drip. And much like Bauback, we will sort of wean it down slowly. And then I'm probably a little more conservative, keeping them in house probably about 24 hours after I turn off the heparin drip, just to make sure everything looks good before sending them out. So many of these patients have traveled a long distance. And so if they have a problem, they're 5-6 hours away and not just down the street. So really want to make sure that they look as good as they can before they leave.
Suhail, do you have any thoughts on anticoagulation in the postoperative period?
Similar protocol. Everybody gets a baby aspirin in the PACU. And then if I have trouble, my first line is that low dose heparin, typically started at 500 units per hour, and don't go for a therapeutic. And then when I've had some bigger replants, hand level or arm level, with mangling, significant soft tissue damage, and then I've struggled with clotting on the arterial anastomoses, I've actually used integralin infusions with a fair amount of success with it. And I honestly don't have a lot of science behind it, except it's the strongest antiplatelet agent that I'm aware of, and it seems to be very helpful, especially when these people that have a significant zone of injury have a thrombophilia associated with that trauma.
I'll stick with you. When are you utilizing vein graft for the artery and or the vein? And have your indications for use of vein grafting changed throughout your career?
The one place that is notably evolved for me is in the thumb replantation. So I think everybody that does replants is equally as irked by doing a thumb replant as I am. And so this was actually an idea that Jim Chang told us when he was our visiting professor, is doing a vein graft on the thumb on the back table, and then subsequently doing the anastomosis in the anatomic snuff box, so that you didn't have to do the contortion of trying to do the arterial repairs of the thumb upside down and backwards. And so that's been really a boon and been very, very helpful for me. Otherwise, I think that for the arteries, certainly aggressive about vein grafting. For the veins, a little bit less so. And part of that reason is that, to me, in my experience, my replants always have a little relative venous congestion. So you're going to try to do at least I try to do 2 veins per artery. And it's a struggle. And many times you're relying upon that re-establishment of the dermal venous outflow network. And so if I have a torn up dorsum of a finger and I haven't sufficiently shortened the soft tissue and the tissues aren't opposed, I'm not going to be able to get that secondary venous egress that's going to eventually allow that digit to normalize. So many times I'm thinking that if I'm got a big zone of injury on the veins and I'm thinking I have to graft it, then I probably need to be reducing the soft tissue even more.
Paige, what are your thoughts on vein grafting?
I'm aggressive about vein grafting for the arteries when needed, especially if it's an avulsive type injury. I think you're wasting time instead of being faster if you're putting together an injured artery, and you'll just be redoing it in a little bit. So I would prefer just to go ahead and get a vein graft, and especially when the mechanism is such that it's a torsion with a sharp injury that created the injury. So that's when I'm really aggressive. I haven't used it as much for veins. I think doing multiple veins is critical because some of them are more beat up than others, but I haven't done it as much. I think you sometimes get some soft tissue loss when you do a very long vein graft for your artery repair. A great example of that is the ring avulsion injury, when you really are doing almost the entire finger in a vein graft. And really that soft tissue over the middle and proximal phalanx really doesn't look that great when you're finished, even though you have great blood flow at the tip of the finger. So I think a lot about those injuries, not that I'm going to do them, but I think a lot about how could we make that better as hand surgeons, because I don't think just the artery grafting with a vein graft creates a perfect digit there.
Bauback, anything to add with respect to vein grafting?
Yeah, I think I tend to have a pretty low threshold for vein grafting. One thing I do want to mention is that you can actually get away with a fair bit with the artery with regards to mobilization. It's not like a digital vein or the digital nerve. When you clip the side branches of the digital arteries, especially the periarticular side branches, you actually get a fair bit of mobilization. And so if the artery is a little bit tight, for example, and you do mobilize a fair bit, you can typically get away with more than you might think. Having said that, if there's any doubt, getting a vein graft from the distal forearm is very easy and very quick. So have a very low threshold. I think one thing that you also need to pay attention to is the other soft tissues in that area. So oftentimes if you need to bridge a large area with a vein graft for, let's say, for the artery, and you're putting in nerve grafts, oftentimes the skin on top may not be that hot either. And so if you're going to harvest a vein graft and the skin is kind of beat up, you can always take a segment of skin with it and do an AVA venous flap, for example. And so that kind of is all part of the same spectrum for us. And if you need a fairly long vein graft, chances are you may need to bring some skin in as well. With regards to the veins, I definitely vein graft the veins a little bit less. And, I have kind of my theories as to why that is, but it just seems like for some reason, when I mobilize these veins and kind of transpose them over, they tend to reach a little bit better. And I think the arteries tend to get avulsed more, whereas the veins tend to rupture right on the site of injury, basically. But having said that, I've vein grafted plenty of veins as well. But that's kind of what I would say. That I've never actually done a vein graft on the back table for a thumb. We just like to put the part on, and if it needs to be grafted, we just graft it. The thumb is a little painful from a positioning standpoint, but we use the so-called Tupper hand. And with a Tupper hand, you can actually hypersupinate the hand very well, and you can get to the ulnar aspect of the base of the thumb without too much difficulty.
Yeah, fellow West Coast colleague of yours, Cody Azari, when he was at Pitt, I remember him giving us a talk on thumb replantation, and he had mentioned that he had learned putting the patient prone helps with gaining access to the vessels. Now, I'm not sure if he practices that, but that was something that I recall from that talk. Suhail, your approach to treatment to Urbaniak type 3 ring avulsion injuries, are you putting those back on?
I try. Obviously, it's part dependent. Thumbs, everything I'm going to try to look at and see what I'm going to have an opportunity to be able to do. And many times these are the situations where, as the patient is being prepared to come to the operating room, I'm going to take the part to the operating room itself and dissect it under the microscope. And I'm going to try to see if that red stripe sign is extending all the way up the vessel to a place that's not necessarily fixable from my standpoint. So I still have a tendency to try, but definitely when I see that amputated part with a long tendon and a muscle belly hanging off the end of it, my heart kind of sinks a little bit in terms of my likelihood of being successful with it.
Paige, what about your thoughts on the Urbaniak type 3 ring avulsions?
This is one of those places that bringing in extra soft tissue, I think if you're doing that really long vein graft is great. Just as Bauback mentioned, borrowing not just the veins from the forearm, but also borrowing the skin, because that intervening skin isn't going to have any blood supply to it. So I think that that's an option here. I think also really counseling the patient and preparing them for multiple stages to get to something that's not just a stiff semi-perfused finger is really important, but no reason not to try with this one.
Bauback?
Yeah, I think I try to save some. Many of them are not salvageable. So just because you can do them doesn't mean you can do them on all of them. And so sometimes I'll come in and you just don't have a target. And if there's no target, then obviously you can't really salvage it. Sometimes, and not all type 3 ring avulsions are the same. You can have a ring avulsion where it's just a soft tissue and maybe a small piece of tuft and all the joints are okay, all the tendons are okay. You can have an avulsion where the bony level, let's say, is through the DIP joints and the FDP is avulsed. You can have a ring avulsion type 3 where it's a middle phalanx fracture, for example. And so all these kind of have different results as far as how much scar tissue there is and how much motion they end up having post-op and how likely it is that they will need revisionary surgery. I think in general, bringing soft tissue, as Paige mentioned, is really important in many of these cases. And oftentimes we'll just debride what doesn't look like it's viable and bring in a fair amount of tissue, usually on the volar side, to not only do a vein graft, but also resurface the volar aspect of the finger. And I think the other one thing about the previous question with regards to vein grafts for arteries, I think that's one of the reasons why I prefer large incisions. And if you're doing let's say a zone 2 replant, there's some folks who just do a little tiny incision proximal distal and see if things reach and whatnot. I just do a very extensive approach and mobilize the vessels and the nerves as much as I can, as much as I need to see if they do reach before I decide if I need a vein graft. And so I tend to make pretty aggressive Brunner's incisions proximally and distally.
What's your philosophy on taking back a replanted digit that's failing, either arterial or venous failure?
Yeah, that's a great question. I think we pretty much decide at the end of the case if this is a take-back replant or not, and we tell the fellows. So generally speaking, the higher stakes replants obviously is a take-back type thing. So it's the digit or the part that's involved and also the level that's involved. So if I'm doing a Tamai Zone 1 replant, the central pulp level, that's not a take-back type of replant. So you try to bleed it, and if it does, great. If it doesn't, then it is what it is. If you got a thumb replant at the MCP joint, and let's say the artery goes down, then yeah, that's something that potentially is salvageable if you feel like you have some kind of a target, especially if there's an inflow problem. If there's an outflow problem, you can potentially leach it for a day or two, see if it gets better. And sometimes when some of the swelling goes down, sometimes the veins kind of drain a little bit better. So a lot of it depends on that. I think having distal targets available, and which means kind of being proximal enough on the part, and having a part that's important enough, and a mechanism that you think is amenable to a take back.
Paige?
Bauback finished up with my thought there. It's a lot about the mechanism of this injury and the zone of injury. So if it's a nice sharp injury and something's going wrong, I want to take that back and optimize. But much like Bauback mentioned, this is something we're going to decide at the end of the case. So if we did everything we could possibly do on the night and we think the part doesn't look that good, the mechanism was such that it was an avulsion and a crush, and sort of the zone of injury is fingertip to mid forearm, and we've got probably no way to get out of that zone of injury, then we're probably not going to take it back. Exceptions there would be kids. I think I'd take them back always just to give it another shot. But in an adult, again, it depends on where the part is, but a lot of times it's the mechanism that drives that decision.
Mm-hmm. Suhail, how about your thoughts?
Yeah, I always take back kids. And similarly, as it relates to the stakes and how proximal the amputated part is, I think that what that underscores is the more severe the injury is, the more you have to be meticulous and throw everything at it from the standpoint of bringing extra tissue, bringing extra vessels, grafts, and those kinds of things, because there's going to be no way to salvage it if it's not looking perfect at the end. So the worse it is, the more that I want to throw at it, because we're not likely to be able to come back and salvage it.
Paige, I'm interested in what your general thoughts on regionalization of replantation access are, maybe in your geographic region specifically. And if I can maybe frame this question a little bit, maybe we'll start with what you think some of the potential benefits to regionalization are.
I think one of the main benefits of regionalization is having a team that is really comfortable doing the replantation. And that's not a surgeon that's really comfortable. It's the operating room team, so that you're not reinventing the wheel every time a replant walks through the door. And, I'll kick this over to Bauback in a minute because he benefits from a team that really knows that. But if the OR team is seeing a replant every month or every 2 weeks, and you're in a large academic institution, it's not the same person seeing the replant every time. And so finding some of the things that are unique to a replant makes that more difficult and makes the case take longer. So, for example, you want to bring the part up from the emergency department while the patient's still getting worked up in the emergency department, dissect on the back table, get everything ready. If your OR isn't aware you're going to do that, that's outside of the normal things that they do for an emergency OR case. But I want to do that because I want to expedite the case to keep everybody moving with the hope of going. So I think from that standpoint, regionalization is great because it increases the volume at a single center for the operating room staff. Yes, it increases it for the surgeon, but I'm not sure that that's quite as important because we're using those skills every day on other cases. You're using your micro skills doing elective cases, not just replantations in the middle of the night.
Bauback, how about your thoughts on regionalization?
Yeah, I completely agree. I think it's all about volume, and the more you do, the better you are, not just from a surgical standpoint, from the surgeon himself or herself or themselves, but also the whole team. And so I think if you're only doing a couple of replants a year, obviously you're not going to be that good at it, just like any other operation. And replants are not as common as other things that we see. There are many more carpal tunnels or breast reductions or things that are common. And so there definitely is a role to make sure that cases get regionalized into only a few centers, because California has roughly 40 million people. So the question is, how many replant centers do you actually need for 40 million people? Well, it's a good question, but we don't really know. But I think if you're not doing, more than a few replants a month, or even at least a couple a week or something, and I count revascs as part of those as well, because from a skill set standpoint, from an efficiency and OR standpoint, a revasc with a skin bridge versus a replant, it's the same kind of case. Now, you don't need a tagging table for that. That's the only difference. But everything else, the heparinocelium and the sutures and the instruments and the fluoroscan, all those things are still the same. So if you don't have enough of those cases, the team just doesn't get efficient enough and good enough to do those in an efficient way. And I think the same goes for the surgeons too. I think if you're doing a 1-year fellowship and in your whole fellowship you saw 2 replants, and there were 2 different attendings and maybe they weren't even there and it was a county hospital and you're just not sure, did you really learn how to do replants? And I would venture to say, no, you didn't. So I think for those reasons, just as Paige mentioned, I think it's really important to have this regionalization so that you can maximize the number of cases done per center.
Staying with you, what do you think the potential barriers to this regional concept are? And I'm thinking along the lines of insurance issues and travel time for follow-up, what to do with the patient that's been shipped 8 hours to this regional replant center.
Yeah, I mean, there definitely are some barriers for sure. I think insurance cuts both ways. So a very well-insured patient is going to be internalized more easily or more readily, even by surgeons who may not be doing replants that frequently, than someone who's uninsured. So in general, uninsured patients are much more easily and quickly gotten rid of, if you will, and referred to a place that probably should be doing them. And what we see is that more kind of commonly cases that are well-insured potentially are being kept in certain systems. Also, I think that certain medical centers, obviously, if they have a level 1 status and they do have surgeons on staff, it's also part of, let's say, a pride thing to say we can do this, especially if you're an academic center. So I can see an academic center, let's say on the East Coast, where there's so many academic centers in close proximity, may not be willing to say, you know what, we're not going to do this. We're going to send it an hour away to one of our competitors, right? So there's also kind of a thing of pride and academic pride, if you will, for places that I have a lot of close proximity. And I think the East Coast potentially, I haven't seen the map, but probably has many more centers within a close area that I can see this happening potentially. But I think, one thing that I know was kind of on, I know, Scott Levin's been working on this for a number of years to come up with this kind of regionalization system and have kind of a carrot and a stick kind of thing where if you're a level 1 center and you are not able to provide replantation services, the only way you can keep that is to have a contractual relationship with the center that does do replantations. And only then can you keep your level 1 status. The thought is that those contracts do come with some kind of reimbursement for being on call for those centers to do replants. Mm-hmm. So I think that if the system is worked out in that way, where groups or certain hospitals are on call for replantation and they have contracts in place with other hospitals, then that could potentially solve some of the insurance issues as well, because at least you're getting paid to take call for those hospitals.
Suhail, how about on the East Coast in your referral region? Are your thoughts similar, or is there a difference in thinking with respect to regionalization from our colleagues on the West Coast?
I think what we have seen is that it's a lack of willingness from our referring institutions to engage in the management of hand trauma. And so what we have found is many places that used to have a hand surgeon on call or had an orthopedic or plastic surgeon that was willing to manage basic hand trauma now no longer has those people on call. And so they really kind of go towards not only just transferring replantation, but hand trauma in general. So we find ourselves at a little bit of a resource challenge in our state. There are 3 centers that do microvascular work, and there are about 7 level 1 trauma centers. So we kind of struggle with these kinds of things. And I wish that going hand in hand with the regionalization, which I do agree with Bauback and Paige on, the more volume you have, the better you're going to be and the better you're going to take care of patients. I wish there was a reciprocal aspect of this that would facilitate patients getting reasonable care back at the communities that they come from, so that we can optimize the outcomes even when we transfer these folks. And I think it's a bigger picture question as it relates to transfer of care, because it's really, really hard to do a heroic type of surgery knowing that someone's going to go back to a community that's not going to be able to facilitate them doing the rehabilitation that they need to, and they don't have the resources to come back to our place where we would do the rehabilitation for them.
With that said, do you think that this concept is close to becoming a reality in coming years, or is it just a pipe dream?
I think that what Bauback pointed out as it relates to the definition of level 1 trauma center, I believe that is imminent in terms of being adopted by the American College of Surgeons trauma section. So I think that it's going to be a matter of some kind of society level mandate that's typically translated to a legal mandate, because most states kind of adopt the definition from the ACS. So I think we're going to see something happening. How the implementation ends up working out is I think another question, but we're certainly going to be having these conversations within the next 12 months.
Mhm. Paige, how about on the West Coast? Is regionalization coming?
Well, just in the San Francisco area, we have at least 4 places that I can think of off the top of my head that do replants, and an additional place that sometimes does them based on whether or not that patient has their insurance. So, and that's, really in a 30 to 45 minute drive by car. So I don't know how that will be operationalized. I actually think that standard definition was adopted by the ACS a couple of years ago. So I don't think we've seen the change that I expected when that language was adopted. And I think it was adopted a couple of years ago, as I mentioned. So I think that this is not going to happen. That's for one of the reasons that Bauback mentioned earlier, which is the reimbursement aspect of this. At an academic institution, my institution is going to say to me, we pay you to take care of hand patients. We're not going to pay somebody down the street to cover just replants, and you can do just hand infections and hand trauma, right? I'm still going to be on call for all the other hand stuff. So I don't see that happening at academic institutions because of that carrot stick phenomenon.
Suhail, I'm going to change the subject a little bit and ask a question, may or may not be controversial, but I'm curious as to whether or not you feel that orthopedic and plastic surgery hand fellowship programs are providing adequate micro training for their trainees. In other words, are we turning out enough of the next generation of replantation specialists?
I think that certainly plastic surgery focused hand fellowships have traditionally had that as a strong suit and certainly attract people with that interest. I think that there's a very broad spectrum amongst orthopedic hand fellowships. Having trained here, Duke, at an orthopedic hand fellowship with a really long tradition of microsurgery, we attract and recruit folks that have an interest in doing it. There are many applicants for our fellowship that are not interested in that aspect, and they go elsewhere. And there's certainly a lot of hand fellowships that don't feature that prominently. So it's very interesting that despite having the resources and in some cases the tradition, that they don't have the charge to train folks in that current way. And I think many people are kind of seeking to design their hand fellowships such that they minimize their hassle in the middle of the night when they're out in their own practices. And then I think that it is a problem that's kind of coming to a head as it relates to more and more people feeling uncomfortable about these kinds of things and not having the skill set to be able to do this. And I see it as more of a problem for the orthopedic trained folks, but it certainly is cropping up on the plastic surgery side of things as well.
So keeping with you, what are some of the ways that we as trainers in a fellowship program can utilize? What are some of the techniques we can utilize to perhaps augment micro-training during fellowship?
So, and I can speak for what we've done, right? So we overwhelmingly, our trainees are orthopedic trained with limited microsurgical experience prior to coming to fellowship. So that there is a significant amount of curricular effort spent towards learning basic microsurgery skills in a dry lab as well as in a animal lab. And then I think as I think somebody alluded to earlier, it behooves the staff to be willing to not only accept those patients that are, I think, equivocal at times, but make their best efforts towards it so that the fellows and the residents get that exposure, that experience of learning how to do it, because nothing beats seeing it in real time. And I think that's, to me, kind of been the burden that I take on gratefully, but you just have to be willing to try to do those cases, even in times where it's an equivocal situation, more for the purposes of education than anything else.
Bauback, I'm going to throw the question over to you and your thoughts on whether or not we as trainers of hand fellows are doing an adequate job of providing micro training to our trainees.
I obviously can't speak for every program, but I think my general kind of gist is that the short answer to that is no. And I think it's not just microsurgery, because elective free flaps are elective free flaps, but it's kind of trauma microsurgery, right? So replantations and difficult revascs. I think that it's one of the ironies of hand training is that more often than not, one of the most difficult operations that we do, which is, let's say, replantation, is relegated to the most junior person there, who is the fellow and resident. So many programs that I've visited, and I've visited many, they'll say, oh yeah, we do X number of replants per year. We do tons of replants. And then you find out, okay, so who's doing the replants? Well, it's the county hospital, and it's really the fellow on call that goes and does a replant. Well, okay, the fellow came from his or her residency, came in. Who's showing the fellow how to do a replant? So even the junior attendings are saying, okay, fellow, go do the replant. But the question is, how many replants has that junior attending done, right? You don't get good at it unless you do it yourself. And so I think many training programs, I'm not saying all, but many of them, people don't want to do them. And I understand why. There are reasons to not want to do these cases 2 a.m. If they're difficult, that you're tired, you got a full day the next day, then the insurance mix is not the best. And so it's one of the ironies, I think, of hand care is that we basically relegate these most difficult cases to the most junior people on the team. So then when those people graduate, are they really well trained? I would venture to say no. And I think for us, you can have someone like Rudy Buntic, who's been doing this for decades, who is obviously a master microsurgeon, master replant surgeon, still take primary call. And if he's on call, he is there at 3 a.m. with the fellow, with the resident doing the replant, right? There's something to be said for that, because he's there every step of the way saying, no, do this way, do this that way. So he's actually instructing them on how to do it no matter what time of day it is. Now, the fellows can have their own cases as well and kind of practice what they've learned from the rest of us who have more experience. But I think only then do you have a program that actually truly trains the fellows and residents in how to do these cases. Not just say, okay, go, good luck, and let's try to do it in less than eight hours or something.
Paige, I'll ask you a similar question to that I asked Suhail. And what can we do if we aren't necessarily with the number of revascs that we're seeing in a given year, fellowship year? What are we able to do to help augment the training of our fellows?
This is where simulation is super important. I think you don't get good at microsurgery doing it once a month for 4 hours in the middle of the night when you've had too much caffeine and not enough sleep. That's not how you become a great microsurgeon. And so you've got to do microsurgery in perfect conditions. You've got to do it in terrible conditions. You got to do it when you're too tired. You got to do it when you've had too much caffeine. You got to do it all the time in lots of different situations. And that comes through simulation, because we can't have, especially when you have multiple fellows, not everybody has an equivalent experience. Everybody has a white cloud fellow and a black cloud fellow, if you will, one doing, a replant every week and one that has seen one in the whole year. So in order to balance that, I think we've got to get simulation in there, and we have to make that part of our expectation of the fellows so that they're really efficient in the OR, because I think I actually am there for every single replant all the way from the beginning to the dressing for just the reason that Bauback said. I'm teaching them how to be more efficient. They're going to have plenty of time to struggle when they're a junior attending and they're there by themselves. Let's do it together this time. And then later you can struggle alone. I think that it's super important for us to teach them those efficiency things, but for them to amp up those microsurgery skills outside of the operating room so that they're really good at 2 a.m.
Do you think that there is an overall appetite for asking those that are interested in performing digital replantation in their institution to do an additional 3 to 6 months of subspecialized training?
That's a very interesting question. I guess in the 1 second I think about this, I don't know where that would come from unless you go hang out with Bauback and Rudy at the Bunkie Clinic, which I've had the pleasure of doing, but I don't know other places that really have that volume. When I get my replants, sometimes it's because Bauback is already doing a 4-finger replant, so he couldn't take another one, so I get it. And that is a very rare situation, I think, in the United States. So I don't know how that would be possible, but I think it's a great idea. Like anything else, extra training, I think, would increase that efficiency. And certainly if you're moving towards regionalization and expert care. But then I think the last thing you have to think about is, where does the money for that come from? Because many people are doing free replants, and that is not going to be sustainable.
Yeah, right. Suhail, I'll ask the same question of you and your perspective, on the East Coast and the institutions that you interact with. Do you think that there would be an appetite to recruit a trainee who has that additional 3 to 6 months of specialized training in digital replantation, revascularization, complex microvascular hand trauma?
I think that it would not in isolation for the reasons that kind of were delineated already because of the lack of volume, but I think as a component of an enhanced microsurgery experience, I think that there would be some appeal to it. We've certainly trained folks that came from an orthopedic background, were never exposed to microsurgery and fell in love with it during their fellowship. And as we all know, you can't learn how to be a great microsurgeon across the board in 1 year of training when you're also trying to learn how to do the other aspects of a hand fellowship. And so I think that enhancement would be of value for certain folks. But I think that it would be the small minority of people that would be interested in taking advantage of it. But I think that having those opportunities available would be worthwhile. And I think that it would require some kind of creative thought about how to put that together, however.
Well, on that note, I think we're going to wrap up this session. Again, I really want to thank Drs. Fox, Mithani, and Safa for coming on today's ASPS EdNet Hot Seat Pod for obviously a most excellent roundtable discussion of replantation in the 21st century. Again, I look forward to hearing more from all of you on this topic during upcoming meetings in the future. And I'm going to turn it back over to Dr. Eberlin to close out the episode. But once again, thanks a lot, guys. I really appreciate you spending the better part of this hour and going through all this with us.
Thank you for having us.
Thanks, Alex.